Here we go. All right, so what we're going to talk to you tonight is about paracycling. Although it is two talks on the schedule, it is all mixed into one. So this is just one kind of streaming talk that's going to initially more or less initiate people to what is paracycling, because a lot of people have no idea what it's all about. And we're going to talk about the Paracyclist, the event, just detail what paracycling is for the warm-up, and then the lap 1 and lap 2 is going to be talking about the paracycling details. We're going to have a mini recovery lap for a break, and then we're going to go into lap 3 and the cool down. Lap 3 is where the medical issues are going to be coming in. So, I think at this point, here we go. So first of all, disclaimer, all the athletes' pictures are mine. You know, they're my personal photos. There's no infringement. There's actually, I think, only one picture of an athlete that was taken from the internet. But all the pictures are mine, and there's no conflict of interest. I have a lot of conflicts, but you're not interested in them, so we'll move on. Just a bit of an introduction. I live in Barrie. I work in emergency medicine. I work at a new clinic that we've opened up called Strive Sports and Exercise Medicine Clinic, and also practice chronic pain management. I was involved with the women's wheelchair basketball team from 2010 and 2016. And although my initial experience at Major Game was with Able Body Games, it's not until I joined my esteemed co-presenter today, Bruce, in 2007 at the Pan American Games in Rio, that I truly got involved with Paralympic events, parasport events, and Pan Am events. And this is what I have done, as you can see from the list there, up until 2016. And I've had a chance to not only work with, but witness fantastic athletes, fantastic individuals, both as not only athletes, but also coaches that have graduated from the field of play to now becoming mentors to their younger progeny. So the experience has been more or less on the fly. So this is a perfect example of on-the-job training. So now let's start with the warm-up. What we're going to talk to you about today, what the objectives are going to be, are basically initiating everybody to paracycling. Just a few things to think about when you're going to be involved with paracyclists, if you're ever going to be working as physicians with paracyclists or as part of a major games in Pan Am's Paralympic events where cycling is one of the disciplines. You may have to see them in the polyclinic, even though you're not involved with a team specifically. We absolutely cannot detail every medical condition possible. That just doesn't make sense. But we're going to try to touch on just a few tidbits and a few elements that are pretty typical and isolated to paracyclists. And we're going to review just a very few elements of medical care and conditions, but most of it is going to be a very quick overview of things to think about, things to be aware of. So now that we're done with the warm-up, I think we should do lap 1, which is a little bit about who are paracyclists. A lot of people often think parasports is the same thing as Special Olympics and all that. It is not. Paracyclists are part of the para program, or very competitive cyclists that have an impairment of any kind. So this is usually detailed by different classifications. And then we're also going to look at the different events that are involved in paracycling. So I think the easiest way to start that is just to look at what classification is. So classification at all parasport, not only in cycling, but every sport has their specific classification that tries to evaluate abilities. It doesn't evaluate disabilities, it evaluates what an individual can do. So for a cyclist, it depends on what they can do on the bike, if they can sit properly on a two-wheel bike, or if they need a front bike. So it depends on what they can do, and then they are classed even within that group under 4 major categories of hand cycles, tricycles, cycling, and tandems. So depending on each level, there's different comparative events. So what I think we should do, before it starts, I didn't think it started, let's just have somebody who's much better than I am who made a video regarding the paracycling event, so then you can be entertained on a really quick overview of all of this. So here it is.
Road cycling made its Paralympic Games debut at the New York Stoke-Mandeville 1984 Games. Track cycling joined the Paralympic program 12 years later in Atlanta. In road cycling, athletes compete on bicycles, tandems, hand cycles, and tricycles. Tandems are used by athletes with hand cycles are used by amputees and paraplegic athletes. There are 5 different sport classes. Lower numbers indicate more severe activity limitation. Athletes with impairments affecting their balance and coordination ride a tricycle to increase stability. The lower the class, the greater the loss of coordination. Other athletes ride bicycles, which are often modified for prosthetics. They compete in 5 sport classes, C1 to C5. The lower the number, the greater the activity limitation. There are 3 types of race: road race, individual time trial, and team relay. Road race distances vary from 30 kilometers to 120 kilometers, depending on classification and gender. All cyclists start together, and the winner is the first to cross the finish line. Time trials are a race against the clock, with cyclists leaving the start ramp individually and the rider recording the fastest time winning. Time trials are 20 to 35 kilometers. Team relays are for hand cyclists only. Teams are composed of 3 athletes from different sport classes and can be mixed men and women. In track cycling, athletes compete on tandems or bicycles, and there are 3 types of races: time trials, pursuit, and team sprint. Time trials are completed individually over 500 meters or 1 kilometer, with the fastest time winning. The individual pursuit is raced over 3 or 4 kilometers, with athletes starting on opposite sides of the track. The winner is the athlete with the fastest time, or the one who catches up with their opponent. The team sprint is disputed over 3 laps by teams of 3 cyclists. Each team member must lead for 1 lap before leaving the race. Paralympic cyclists will put on a thrilling show of lung-busting endurance, explosive speed, and tactical intelligence.
There you go. So I guess I could just stop now and be all done, and Bruce can take over. But I think we should just talk a bit more details about the different elements. So we talked about hand cyclists. So this is hand cycles, tricycles, various bicycles or cycling as a class, and the tandems. So if we look at the hand cycles, like they mentioned, there's various classes depending on the level of disability. Lower numbers indicates restrictions in both upper and lower limbs. Higher numbers would indicate restrictions in lower limbs. Now you can see the biggest difference is some of them are actually lying down almost, like these individuals, they're all flat on their back, versus some individuals are sitting up or kneeling down. So the difference usually between these individuals is the people on flat hand cycle bikes usually have a higher spinal cord injury. They do not have trunk ability. They cannot activate their abs. They cannot activate their core. Basically, they can't sit up and hold themselves. So they are lying down, sometimes quite far down, like we see this individuals here, because depending on their level, they may have to be strapped down even farther up on their chest. Versus individuals that do have a lower spinal cord injuries do have activation of their core, so they can physically use their core, their abs to push the actual cranks with their arms, and they can lean a little bit more into the turns themselves. If we look at trikes, they're usually depending on individuals that have balance issues with, depending on the level of impairment, they're going to be based on similar abilities again. And basically, these are individuals that may have impaired muscle power from various types of muscular dystrophies. They can have ataxia from various sources. It could be a post-CVA, it could be post-TBI, it could also be cerebral palsy. All of these different classifications or medical conditions may lead to an individual having balance issues, and therefore they can perform on the trike for a balance, for the balance control. Now, cycling is kind of interesting. It's just called cycling, but it is the classification that they use two-wheeled bikes, but they are, the modifications are endless because it depends on the impairments. If you have arms, if you have one leg, if you have part of one leg, if you're an amputee. So there's all sorts of different type of modifications that all start with a standard bike, and then they add parts or remove parts. And depending on the level of impairment you're going to have, you'd be matched with either a 1 or a 5, depending on the class. And that means that they may have a race where the C1s compare to the C1s. And so you're trying to match abilities again. So the modifications are fascinating. You can have a high-end BMC race bike. One leg, well, and then put a place for your hip to be sitting on. This person would have an above knee amputation, and therefore their hip would sit there, and they may or may not strap their hip there, so they can use their pelvis to crank and use the right leg with more power. And you have individuals like her again, if you only have one leg, well, you only need one pedal. So you take this away, and then you just go on and ride on. You can have fantastic modification. This is one of our Canadian athletes, and this was in Rio, and he has 4 limb abnormalities due to congenital malformations. He has 2 below knee prosthetics that are tied to his bike, and he has very complicated handlebars to try to be able to maneuver the bike. The easy thing is on the track, you don't have brakes, so who cares about trying to hold on to the brakes because it's all dealt with the drive. Also don't have gears, so he doesn't have to do any of that. Where it gets complicated with him is when he's on the road bike and he road races. How do you handle the brakes? His brake on his road bike is actually a lever on the back of his saddle that he pushes with his bum by pushing backwards so he can brake, which is fine when you're going straight. But imagine if you're going downhill really fast and you're trying to push your bum back and you press the brake, that tends to push your body forward, which releases the brake. So it takes a lot of skill to be able to manage himself in various terrains. And then there's other individuals that may have prosthetics that are physically connected to the bike. And this individual, Mark here, he has an arm amputation, and he has that sleeve that puts in. It's a non-articulated sleeve. There's no hinge over here. So this is a straight arm, and it's actually Allen keyed to the handlebars. So just think about a crash. If he crashes, the bike goes with him. It's not as if you're going to have the bike flying somewhere and he goes the other place. The bike goes with him. So it increases the level of potential traumas that you can deal with when you have a piece of machinery that's physically connected to you with its individual torque that it can put on your body. So these are the modifications, and they're endless. So we can spend the whole day looking at cool bikes and what they do to make them very efficient and also adapt to the athletes themselves. Tandems are very easy. You have somebody that has a visual impairment, they're in the back, and the goal is to have the biggest engine in the front. So the goal is always trying to find an athlete that is at the international level, that is not competing with the national team at the able-bodied level anymore. And I think it's a year that they have to be removed from that. And then they're allowed to be a pilot for one of the athletes. So the events, what kind of events are these guys participating on? You've seen some in the movie or the little video, but on the track, it's very limited because you're not going to have trikes and you're not going to have hand bikes. It's only bikes and tandems. And we've talked about the individual pursuit, the time trial, the kilo, and all that. So there's not a lot of different events on the track simply because you limit the different types of not as much the classification, but the elements, because there's only 2 of the different types of bike segments. Because again, tricycles and hand bikes are not on the track. Now on the road, it's a free-for-all. Everybody gets to play over here. So the road race is a lot of fun. There's a lot of activities. You see people lining up, and these may have different impairments. You see this person here, his arm's actually tucked into his jersey. This person here doesn't have a hand. This person here doesn't have an arm. So you have various abilities that would be taking off into that event. And you see an individual like that to say, hey, that's not fair. This individual here has 4 limbs, but may have some muscular weakness, making him not able to hold his handlebars very well, versus this person here may be able to handle is handlebar as well, and therefore, again, they're matched with abilities. And then we have the tandem, which is self-explanatory. This is actually two of our ladies that got a bronze medal at the Paralympics in Beijing over here with that ride. And then we have the hand cycles. Again, they are matched with their different abilities depending on if they're on knees or sit, or in what they call the bucket. This is a bucket, or if they're lying down. So everybody gets to have fun there. Time trial is also a very interesting event because on the time trial, everybody goes and it makes a lot of activities, and therefore the whole cycling event are very busy, similar to the pool where you have so many different classes. So the tandems are going at it, not sorry, the tandems, but the trikes are going at, hand bikes are going at it, the different types of hand bikes are going at it, and this individual here, you may not see, has a below-knee amputation on his side, but then the various types of cycling, the C-class, they go at it as well. And of course, the tandems are just hammering as well. So the road ride, the road event outside of the velodrome is quite a busy event for all sorts of different athletes. So that was lap one. So now you've met, you've been familiarized with who these athletes all are. So let's look a little bit about just the whole association of medical care with individuals like that. So just medical considerations with or associated with the paracycling world. So is there a difference between being a team physician with an able-bodied cycling team or covering a cycling event that does have individuals with impairments that will be friends? Actually, not that much, but there's just a little bit more homework and a little bit more to be done. So if you look at your team physician role, where you're going to be knowing all of your athletes really well, as you should in able-bodied sports anyways, but the medical conditions that could be associated with athletes' classification, it could be spinal cord injuries, could be various neuromuscular conditions, post-CVA athetosis, and the ones listed over here, and amputees, which can have overuse of existing limbs and stomach concerns. So you have to be a little bit more aware of what brings the athletes to the team, and then you have to familiarize yourself with their medical conditions. So there's a little bit more homework to be done to make sure that you're very much on top of the different medical paths of all of your athletes. So for spinal cord injuries, as you move along working for a prolonged period of time, you need to be considering bone health. They have a higher incidence of osteoporosis due to non-weight bearing, non-muscular traction, and lack of gravity on some of their long bones. So you have to be aware of that and a higher risk of fractures. Skin health is very important. You know, the obvious one is the sensory deficit increases the risk of pressure ulcer, but also the just even burns, just the whole concept of showering or taking a bath. Some individuals will have big burns because they don't feel that the water is too warm. So scalding can be detrimental for an athlete who prepares for 4 years to the Paralympics and they get a big burn on their limb or on their foot right before a major event while they're over there. It can be quite troubling. So there's a lot of things that you have to be aware of as you move forward with the team. And of course, genitourinary health with catheterization and risks of UTIs, which is ever present. And when you prepare for that event, you're going to travel with your team. Very similar to able-bodied team cycling, you have to know what's going on, plan where you're going, who's going to be there, what services you have available to you. You have to prepare and plan where the area is going to be. Is it going to be a major center or in a rural area? The travel itself, the time zone traveling, the nutritional challenges, acclimatization, health risks, medical service at the destination. These are all the same thing that one would do if they would be traveling with an able-bodied cycling team. But in this situation, you may do something different. You can't just assume they're going to be sleeping on the big trip all the way to Tokyo. You may want to assure that the athletes you're traveling with are going to be hydrating themselves well. They may need to bring their custom wheelchair seats into the plane to sit on them, because for them to sit in something that is physically made for them and is custom might be better than sitting on the airplane seat itself. You want to encourage them to hydrate to decrease UTI risk, but a lot of athletes don't want to because they don't want to get out of their chairs, because it's a pain in the butt to take the little, what they call aisle chair to be moved all the way to the back or to the front, wherever the bathroom is, and to catheterize over there. So a lot of times some of the athletes say, I'm not going to drink at all because I don't want to go to the bathroom, but it's important to make sure that they do hydrate, they change positions, they try to limit pressure issues and or UTIs, because it is not unusual to arrive at destination and then you have an athlete that says, I think I have a UTI within 1 or 2 days. Thermoregulation challenges are always a concern. Skin issues, we just talked about it, and stump edema. You may have experience going on a long plane trip and then, oh, your shoes are so tight, your feet are all puffy. Imagine if that's your stump and it doesn't fit in your prosthesis because you took it out during the flight because it was bugging you, and now you can't put your prosthetic back on. That becomes a big issue. And then you have stump breakdown and abrasions because of the edema that you gain during the plane trip, and you try to wedge yourself into the socket of your prosthetic. So these are all things that you have to be aware of, think of, plan for. And that's the beautiful chair that most athletes really don't like to do, the travel from wherever aisle seat or maybe a window seat that they're in and all the way to the back to the bathroom. Now, is there a difference by covering cycling event? If you're covering an event and you know there's going to be paracyclists around, things that you may need to be staying on top of are very similar to what the team physician coming in with a team does, but some athletes don't come in with a team. So then you may need to be a little bit more aware of the individuals coming in from a different team that may have language barriers. Like I know when we had the World Championships here at Milton, I think it was in the spring, I forget when I was, but I covered an event and they had teams that were Spanish speaking only, and they didn't have any medical personnel with them. So when they had some concerns with their health, it's pretty tough to sort it out. So that adds a difficulty. But training load, overuse of functioning limb, that affects daily transfer, not just the sport and performance. It affects everything that they'll do if you have an individual that's chair mobilizing on a regular basis. Thermoregulatory regulation impairments are tough because you may be competing in really wet weather and cold weather on a road race, or you may have the really hot, super dry environment of the velodrome. And so trying to manage this with fans and have the availability of fans or a lot of spray bottles for water, or trying to have any kind of elements to cool down they warm up on the track itself or in the middle of the track. These are all things that you need to be really on top of, because it's something that the athletes will have a bit more difficulty dealing with. Pressure ulcers that you may need to deal with at the track itself, and evaluating trauma is always tough when the person doesn't feel their limbs. So how do you say, how's your leg? If the person says, well, I can't feel it. I couldn't feel it yesterday. I certainly can't feel it today. So it may be broken or damaged, but you don't know. So these add complexities. And managing concussions in athletes that may already have cognitive deficit, that may or may not be able to have the obvious presentation features of a traumatic brain injury, make you have a lot of difficulty if you're covering a cycling event and you're supposed to decide on participation of an athlete that crashed to decide if they're clear to take place. Very complicated, and to be honest, there's not a lot of great answers for this at this time. In Beijing, not dissimilar to able-bodied healthcare, the medical considerations themselves to manage a team, to be a team physician, or to manage a cycling event, are not that different. You just have to be aware of the medical conditions and make sure that you plan for them, that make sure that your staff is well-trained and has an awareness of the complexities of these different types of populations that are come in and participate and not only train, but compete at a high level. And you have to have various equipment that you may not have been thinking of. An example, you may want to carry a little bike multi-tool because, an example, one of your athletes may be bolted to their handlebars and you need to take an Allen key to get their arm off the handlebars to be able to mobilize them. And if you don't have one, well, there's not usually one in your medical kit. So a little bike multi-tool is always nice to have at these events. So there you go. So that was lap 2. So we're going fast. We're trying not to bore you too much. I hope we're not going too fast. And usually when I do these presentations, I like to entertain back and forth conversation with the audience and it's difficult to do here. So please make sure you have, if you have questions, make sure you put them at the end, and Wade will be able to manage that. Now I decided to take a little recovery lap here, just a little break to take time to, again, mention that this event was supposed to be a CME event on Saturday in 2 days, the day before the Tour de T1D, which is a ride that myself and Darlene have organized for support of type 1 diabetes as Canada's biggest, and I think now one of the only large-scale bike ride to support type 1 diabetes, because there isn't any. So we've got one, it's in our own backyard. It will be virtual this weekend. We will ride it on live, but you can participate in a virtual ride associated with the webinar, and I think Helen can probably put the login methods to be able to join us on the ride. I think there's already a bunch of people that are attending tonight that are adding their little kilometers day by day to the event, and Dawn has promised she's going to do the whole smacking 100 kilometers on Sunday, so we'll hold her to that. So I just like to thank again Chasm for adding this webinar as an event, plus connecting it with the ride that we hold dear to our hearts, as my son was diagnosed 4 years ago now at the age of 14, and we're doing this in his name. So please join us, and next year, come and join us again. It will be happening next year live, I certainly hope so. Okay, sorry about the shameless promotion, but I kind of had to. All right, we've recovered. Let's go to lap 3 and talk medical stuff. What are the common injuries and illness in a paracyclist? Are they different? You know, is this really a different? This is always the question we get, and Bruce, I'm sure you've fielded many of those questions, and Andy Marshall has fielded them as well. People say, oh, is it different to work at the Paralympics and the Parapan-Ams? It must be different because these athletes are different. Well, are they really different? You know, or what are the medical health concerns in a paracyclist? Are they really something you need to be different? Some of them are common to every cyclist. If you rode a bike, if you are riding a bike, and you will have some issues depending on the volume and the training that you do, but these are common to able-bodied and paracyclists, and some of them are only specific to paracyclists. So some of the common ones are the obvious one. You ride a bike, it doesn't matter if you got like this lad over here, if you have one leg, two legs, or whatever, but you may get head injuries, and you may have mental health issues and stress, anxiety. We've talked about a beautiful presentation by Carla that was on the first night regarding to mental health issues in cyclists. You should be able to access that because they are archived. And the exposures to trauma, how it affects the cyclist. Well, these are not something that is specific to paracyclists, but every cyclist are going to be faced with these issues. Fractures, nerve palsies, abrasions in the forearms and the hands, they happened. You can have abrasions, fractures in your legs. You can have overuse, which are more common in amputees because you have one leg and it's just doing all the work. Well, you may have a little bit of more of an overuse or an overload issue compared to somebody who has two limbs. And of course, saddle sores are part of the business. And I think Wade is going to talk to us about that next week. He's got a fantastic presentation. I think Wade has tons of pictures as well, but anyway, we'll leave that to him. And a sore back, you know, until it's all about life, many people develop a sore back. So these are common issues to all cyclists. They're not just paracycling issues, but you will have to deal with them in these individuals. Now, what is specific to our paracycling athletes? Well, it depends on who you are, meaning it depends on what class you're in. If you're a visually impaired cyclist in a tandem, well, you probably don't have anything specific to you compared to an able-bodied cyclist. But when we're talking about specific issues, we're going to be looking at the amputees, which are individuals on bikes. We're going to be looking at individuals that are on trikes or various types of mobility, cognitive issues, balance issues, and we're going to look at people that are completely asensate or the spinal cord injury folks. So if we look at our cycling friends, and again, the trikes, and we're going to look at spinal cord injuries, so we're amputees. So some of them have limbs that they use a prosthetic. Some people simply take their limb off. But the ones that are going to be using their prosthetic, they'll often come back and they say, hey, doc, my stump hurts. So that's the initial kind of chat you're going to have with many of these individuals. And you're going to look at three big categories. One of them is fit. The other one is going to be the bone, and the other one is infection. So basically, one of them is related to how it works in your prosthesis. The other one is how the frame is, meaning the bone, and the other one is going to be the soft tissues. So it's kind of a good way to separate them. So if somebody has fit issues, common things you're going to see are just a change in stump size because of air travel. I mean, like I mentioned earlier, if you think your feet swell, imagine if your stump swells and starts to look like that because you took it out of the prosthetic, or because it was in, but it wasn't in right. It wasn't really fitting perfectly well in the socket. There was a little bit of room to expand, and it just basically expanded and became edematous due to constricting areas around the proximal part. And so the distal part becomes very, very sensitive, very sore. You may even have an abrasion on it. So the stump edema syndrome is something that is relatively well known to any athletes who is using a prosthesis, and at the same time has traveled, and some people will call it choking. And it could be because the prosthesis itself slipped a little bit and you lost your suction or something like that. So different things that you could do with that situation. Well, the first thing you do is try to prevent that. So keep the prosthesis on and make sure it is really jammed, perfectly fitted, and you've got your vacuum perfectly organized, that you don't have air pockets inside. If you already have the condition, you need to let it decongest. You can't ram it into the prosthesis again, then you're going to be asking for trouble later on. That happened to one of our athletes. Different situation for prosthetic issue, but imagine if you're used to walking just normal around small volume of walking, but you decide to have, or your team has one afternoon off at the Rio Parapan Ams, and it's travel time. So you and your team are going to travel everywhere, walk everywhere, hike up to go see the big Jesus statue and all that stuff. And you spend your whole day sweating into your prosthesis, walking way more than normal. And by the end of the day, you say, my stump hurts, because now you have an abrasion. So unfortunately, you can't wear your prosthetic for probably at least a week until that settles down. And so now you're walking on crutches. Well, you're not used to walking on crutches. So now your shoulders are killing you and your arms are sore. And you're in a sport of sitting volleyball, which means your hands are above your head all the time when you're training. And it's a new sport for you. So right now we're just kind of talking about at least 4 or 5 different areas of overload and concerns that could have been prevented by just being really aware of the amount of walking. But then what happens after involves multiple different areas of care to be able to get that athlete to compete at the level that they're supposed to. And so this is why the therapists are worth their weight in gold at these games. So chronic poor fit can lead to skin change ulceration, can lead to infections, thickening of the skin, and you can actually get a pre-squamous cell carcinoma, a change called verrucous hyperplasia that can develop, and that's very chronic poor fitting stumps that would develop that. So then we talked about the bone. What about the frame in there? Well, 2 big things that you think of is the amputation itself. Was it done really well? Was it done with a proper positioning of if you're talking about a below knee amp, let's say, if you look at it, if there's any kind of sharpness to that edge, this may lead to pressure on the soft tissue. This is actually an x-ray with a prosthetic on, so you can see the actual cup there. So this would be the soft tissue stump and some areas of the material and foam and cushioning that they have inside of the prosthetic that you can't see. But this can lead to a bit of an issue with pressure points, and that might need a revision in the future. And sometimes it's also if the pressure of the cup itself or the sleeve or the socket is putting too much pressure on the end of the fibula that can cause some problems. So amputations are very specifically done, and also they have to be done in a perfect way to lead to a really good distribution of weight without pressure points. So the bone itself can be a problem from the get-go if the amputation is done improperly. And then you have which is basically calcification in the soft tissue that can develop, much more common in blast victims. A lot of this was studied, a lot of the research on this was after Iraq War, Gulf War, and there were a lot of blast victims happen, and so they could look a lot at the different presence or incidence of HO in blast amputations versus people that get amputation because of motor vehicle trauma and various other things. But anyway, as soon as you get bone formation, it calcifies, meaning it solidifies or hardens the soft tissues, creating very different pressure points. And therefore that pressure point is not what you're used to or what you had your custom sleeve and socket made, and therefore creates abnormal sensation and pressure and pain into the soft tissues that can lead to further breakdown. So that might need surgery. Infection, any soft tissue can get infected. It may start with your garden variety scratch or an abscess that can develop into an abscess. It can be just because of an abrasion, can be anything. And of course, it develops into osteomyelitis, and you get into real trouble. And so prevention of infection starts by good skin care and making sure that you don't get into trouble in the first place. But if it's there, individuals with an infection of the stump are usually not going to be seeing their prosthesis for quite a long time before this is completely sorted out. And of course, if they're competing, if you've got a track athlete, or if you got an athlete that's on a bike, and because we're talking about paracycling, if he's got a below-knee amputation, he's got an infection, you can pretty much write off their games right there, because there's a very hard way to deal with a serious infection like this within a few days. Now, this is a special category that's kind of interesting. So TBIs in parasport, which, as I've alluded earlier, can be a difficulty when you have individuals that do have existing cognitive issues to start with. If you have somebody that has verbalization difficulties, if you have somebody that has memory issues to start with because of whatever medical condition or cause that led them to become a para-athlete, they might have existing difficulties that can make any kind of evaluation of a post-concussion situation very difficult. But this is an athlete, a specific athlete that I've seen and worked with at a couple of games. She's fantastic. She's from Quebec. She does not have a cognitive issue. She has, unfortunately, been kind of troubled with all sorts of physical issues. If you look at that, she was hit by a car at age 14 and has some permanent musculoskeletal dysfunction. Not only that, she had a myelitis, what they suspect was a viral myelitis that led to permanent functional deficits in her legs and balance issues. So we're at the Paralympics in London, and I've been there kind of organizing the team before the athletes come in, and then athletes come in on, you know, every day there's new athletes, new teams coming in, and don't I see Marie-Ève coming in a wheelchair being pushed by her coach, who I had worked with at many games before. So as I see them, I kind of do the big wave, hey guys, how you doing? And the first thing that Eric and Bruce knows Eric very well as well, he's a man of very few words. He goes, Doc, we need to talk. In French, of course, he's Belgian, but he goes, Doc, we need to talk. I go, uh-oh. That's not the welcome and the hello I needed to have. And it's right before dinner time. So I go, they just came off the plane, and the first thing he wants is talk to me. And so I said, what's going on? I said, I'll meet you at the clinic at such and such a time. So what happened when Marie-Ève is we're worried about a concussion. This is now August. We're in late August in London. She was at the World Championships in July, and she had a nasty crash. She planted into a fence. She was confused and disoriented, which is very easy to assess because, as one of the other coaches says, she had her front wheel jammed into the fence, still trying to bike forward into the fence, telling the coach, I'm fine, coach, I'm fine. He goes, Marie-Ève, you're into a fence. You're not fine. She goes, I'm fine, I'm fine. So evidently, her judgment was way off. So she was pulled off the course, and then she was sent home, and she said, you know, you can rest for a few days, you should be fine. But then she had difficulties at work. I forget what type of work she does, but she's involved in a lot of computer work, and she says she was missing meetings. She had difficulty with her agenda. She was having a lot of trouble just managing her, what she considers normal work. But she never thought she had a concussion, just thought I had a crash, I didn't feel good, and I just kind of took it easy for a few days. And like many people with concussion, it was a hot day, I didn't drink enough, I didn't have breakfast. They start to blame everything else. So she says, what is it, a concussion? So now she asked me to try to diagnose a concussion that happened over a month before. And if it was a concussion, can I compete here? So it becomes very difficult to assess all that. And everybody who has dealt with athletes with concussion can see that this can become quite a challenge. Unfortunately, after a lot of time spent with her, it was evident that she was still really not recovered from her concussion, and she did not compete in London. So she made the whole trip, trained hard, and she lost that event in 2012. So like many athletes, she lost that window, which was quite unfortunate. So the difficulties with traumatic brain injuries in the para-athlete is a lot of the things that we normally do regarding immediate on-field assessment. Well, if you have somebody that already has balance, how do you define a change? How do you define their Maddox questions that are part of the concussion assessment if the person has a cognitive, speech, or hearing impairment? If somebody has pre-existing symptoms of pins and needles, weakness, some parts of their limbs may have some partial paresis, how do you define that they have a weakness or lateralizing signs? Cognitive screening by itself can be difficult. And the neurological screening, well, if you have a visually impaired athlete, well, you can't ask them if they're able to read, if they're able to track and not able to do the visual ocular motor screening. There's so many different things that we do instinctively when you have an athlete that has a concussion that are not going to be practical for the para-athlete. Dr. Dimi Kisik, one of our esteemed CASA member from Ottawa, who is now a member of the IPC Medical Commission. And they've looked at this, looking at the issues of concussion in parasport. And as expected, like many things, there is very, very poor research. There is very poor data. There's not a lot of answers out there regarding how to manage this very specific situation in the different classes of para-athletes. So a great article over here if you want to go read it, but the article, by the end of that, you end up saying, well, we just don't know, more research suggested, and evidently there's more research that is suggested. In some wheelchair mobilizing athletes, there is, as opposed to the balance error scoring system, the best score that we do for able-bodied athletes, there is a wheelchair error scoring system, the WEST score, that has been adapted and validated, that has been used in various sports, like the wheelchair basketball team where we're using it. But again, there's just not great research. So the best is for the team physician often to know their athletes really well, to know that they're not themselves. And it's very soft, but that's sometimes the only thing you can go with. But the easy one is if an athlete has got their wheels stuck in a fence and they're still trying to ride through it, that's a good sign. I think that's a pretty hard sign that an athlete needs to come out. And so that was TBI. And here's a good, a fantastic example of this young athlete. This is a young lad, and it's interesting, this whole sentence that's mentioned over here, I kind of would be able to say the same sentence because I've seen him compete in Beijing. I've also seen him compete in Rio, and he's simply faster than he was so many years before. This guy is a machine, but when you look at him bike, his head is bobbing all over the place. When you look at him walk, he can barely walk. He needs help sometimes with his friends. He walks with a very classic cerebral palsy gait. And you'd see him walking in the street. You go, oh, this poor guy. But throw this guy on a bike and you will not catch this guy. At one of the event, I think it was Toronto, I'm trying to remember, was it Toronto or London, but basically his qualification event in the morning, he established a world record. And on this, the second, when they have the second group that comes in, he blew his own world record. And in the finals that night, he won gold by blowing his 2 world records that morning. So this guy had 3 world records in one day, and he just keeps getting faster. So it's fantastic to see these individuals compete, but unfortunately, you're never going to be able to do any kind of balance testing, coordination testing, or anything with a lad like that because he already has the tremors and the difficulty with coordination that comes with his condition. So it makes difficult decisions. If he crashes, you have to say, are you ready to go? So spinal cord injuries, this is that one picture I talked to you about. That's not mine. I grabbed that off the internet because Canadians never crash in their hand bike. That's my version. But so this guy crashes and you're rushing to him, and then you ask him, how's your leg? He goes, I don't know, I don't feel it. So did he break a limb? Did he break his pelvis? Did he break anything? You have no idea because he can't feel pain. So you can't say, does it hurt here? Does this hurt? Are you able to move your legs? Well, no, I haven't moved them for 10 years. So the evaluation of a crash, spinal cord injury, hand cycle cyclist is a bit challenging. And what you end up doing is you overprotect everything during a crash and you investigate because you have no idea what to expect. So you can have osteoporotic fractures with minimal trauma. I've had one of my, the basketball athletes that actually broke her tibia transferring from the bed to her wheelchair. So she didn't fall downstairs, she just moved basically. And predominantly it's going to affect the pelvis and the lower extremities, which makes sense because they're the level below the spinal cord injury or the level of impairment. And it is not the same pathophysiology of bed rest or space non-gravitational kind of demineralization. It's very different. It's based on all sorts of different mechanisms that are both acute and chronic. So if you look at the chronic, well, first of all, within 1 year, somebody with a spinal cord injury may see the femoral neck, midshaft femur, and distal femur dramatically decrease in their mineralization. So they become osteoporotic really fast. And it's based on some acute changes, like within even a couple of weeks after the injury, you can start to measure increased calcium loss into the urine. It peaks at 6 months, and it's much volume that's on bed rest due to various conditions. And so they suspect the spinal cord injury, the neural effect, will increase both osteoblasts and osteoclastic activity, but there's more chewing than building. So therefore, you will lose more bone just because you've got a spinal cord injury. It's not simply because you're lying in bed due to your spinal cord injury. And so there is, of course, the concern with lack of muscle traction, gravity, and effect, but also there's some neural factors that are at play over here. And chronically, your parathyroid hormone backs off because you got all this calcium floating around in your serum, but eventually it starts to turn around and then it stimulates the parathyroid gland and then it augments even more bone resorption. So basically, you've got two mechanisms to increase the risk of osteoporosis in these individuals. So you have to be really aware in spinal cord injury crashes, or athletes who crash, that you may have need investigated early. So a lot of imaging just to see what things look like. And this is in any sport, not just paracycling, of course. So if you think about it, well, you need to investigate it. And basically, I should say, you should think about it and you should investigate everybody in this situation. And that's the few little conditions that I thought would be more specific to our amputees, to our balance or coordination impaired athletes, and also spinal cord injuries that I thought would be good to just highlight. And so for a cool down on this, who are the paracyclists? We talked about them. So at this point, you should realize that after this whole presentation, figure that they're basically paracyclists are athletes and they're cyclists. That's it. That's all. They're great athletes. They perform at extremely high demanding level. The coaches are demanding, and they put them through severe, intense workouts to be able to get the best of performance. So these are not taking it easy going for a ride in the park. They're very much on the same kind of path as any other athlete in the training, expectations, programming. And that's why a lot of them were very ready for the Tokyo Games this summer. And now they find they're going to have to peak a second time next year. But these are highly trained individuals, but they're also just cyclists. And everybody who bikes knows that most cyclists are just fantastic people. They're just great people. They're fun to be around, and they're fun to ride bikes with. And it's just fantastic people that we get to meet at these games and just make all sorts of connections and networks. So they're athletes and they're cyclists. And then at the end, not right now, but I think Wade is probably going to entertain questions way at the end. And that's as fancy as it gets, guys. So thanks for being awake, if you're still awake. And now I think I'll just get the screen and I'll give it to Bruce. Thanks.
Actually, that was fantastic, Richard. Thanks again. I always very much appreciate your talks. We'll do questions for your talk. We're doing them kind of in between the sessions, so
Okay.
we can take yours now. I can read them, or if you want to click on the Q&A, you can.
Yeah, I got there. Initially, I said to prevent UTIs. Any experience either? D manuals, I've not heard of that, and to be, I have not heard of anybody using it either. I know that I've used to hear some reports on that substance being used for decreasing chronicity of migraines, but I've never heard it as a nutritional supplement for UTIs. So I haven't seen it, but that might be, again, something to consider. A lot of people have, of course, talked about cranberry juice, but the evidence was not very exciting for cranberry juice. And so some people are kind of looking at it saying it's probably not doing as much as we thought it used to. Kristen Campbell asks, how do you manage heterotopic ossification in amputees? Well, it depends if it is simply there and not causing a problem found on an x-ray by chance, you don't do anything about it. You just let it be. But if it starts to affect the stump, if it starts to affect the pressure points, sometimes the easiest thing to do is just try to get a stump revision, not a stump revision, a prosthetic revision or a socket revision to adapt to the different pressure points. So you kind of try to not let it lead to the definitive end story is often going to be a revision. But some people, if you start to see it developing, there is some evidence on using NSAIDs for it. I'd have to leave it to the orthopedic specialist, or maybe Andy Marshall, who would know when to start initiating anti-inflammatories to try to see if they can decrease the ossification happening. Some people have even used some of the biphosphonates, but I'm not well versed into the research on that. But initially, what you try to do is try to adapt the prosthetics so that you don't create pressure points. Bob McCormick, would you hold a paraplegic from competing with a tibial fracture? No pain? Absolutely not. On another talk that I do, the basketball athlete that had fractured her tibia, she was, of course, not caring much about her fractured tibia. She was more caring that she was in the finals for University of Alabama for the NCAA championships. And she says, I don't want to miss my game. So the easiest thing is manage to, well, of course, phones and another version of Zoom or whatever, but because she's in Alabama, they managed to make a cast for a bit thicker fiberglass cast for her that would be putting her leg in a perfect position that she would be in her game chair. And so it covered the foot, just typical kind of long leg cast, but a 90-degree at the knee and would go just above the knee joint. So it would actually keep the whole tibia completely immobile. And she played, she competed, and they won the championship. So depending on the area of the break, if it's not bothering them too much, and if it's an individual that has a low spinal cord injury, because if you have a high spinal cord injury, like T6 and above, you could have a fracture that they may not feel painful, of course, but it may lead to autonomic dysreflexia just because the base. For her, she had a low injury, and as soon as we immobilized her, she was cleared to go, and it's within the acceptance of the rules of the game that they're allowed to play with that. Probiotics with cranberry, I'm more impressive than the juice. I don't have experience on that, Claude, regarding the probiotics with cranberry juice for preventing of UTIs. I know probiotics have now gathering a lot of speed and energy with their benefits on not just gut health, but various types of metabolic features through their gut health, but I haven't heard about the UTI association. And that's all the other questions that I can see.
That's great. Thank you, Richard, and thanks for the questions. We'll move on to our next speaker. Our next speaker is Bruce Davidson. Bruce and I work both with Cycling Canada. Bruce works with our mountain bike team. Last year's version of this event, we had hoped to have a mountain bike topic as well, but we couldn't quite make that logistically work. So I have strongly recruited Bruce to help out this year, and is going to be talking on mountain bike and medical coverage of MTB events. So I'll let you take it away, Bruce.
Thank you very much. It's always hard to follow such an eloquent speaker, but I'll do what I can. For those of you who read the email correctly, you'll know that I'm talking about medical C overage of mountain bike events. And I didn't really know what that meant. So I'm just going to talk about what I felt like talking about. I've really enjoyed the other talks, but I've noticed something's been missing, particularly amongst the docs that have disciplines in Canadian cycling. So I'll fix that right off the jump and talk about the fact that I'm going to talk about the best kind of biking, mountain biking. Now, the way I propose to do it is I'll talk about where mountain biking came from. And more using the term mountain biking really doesn't mean very much. It's like saying sports. There's so many different machines with so many different things being done on it. We'll touch on some of the different disciplines to give you an idea of what you might face. Now, if I have time and get around to actually medical talk, we'll talk about some of the stuff that's the same and some of the stuff that's different. And as my want, I love talking about terrible injuries and kind of making fun of them. So I'll also try and touch on stuff that's very different. Now, at the end, I'll also try and wrap it up so you can maybe learn something from this talk that'll be an advantage in the future. Being a speaker that pays attention, I put the disclosure slides. Sadly, I don't do any research. I have no grants. I get no honoraria for this, sadly. Hint, hint, hint. I do get a small consulting fee from the Canadian Cycling Association to cover these crazy mountain bikers. I will be biased. Everybody knows that. I'm just not paid to be biased. So let's start to play. If you Google mountain biking, it'll say that it was invented in the late 70s in Marin County, California. Now, as someone of that vintage who grew up in Vancouver, I really resented this because they were sort of breezeway stoner guys that were hanging around the industrial education shop, learning and becoming very good welders to put their bikes back together because they destroyed these old clunkers from riding on the North Shore of Vancouver. Now, the guys in Marin County left a legacy to mountain biking because they founded million-dollar companies such as Gary Fisher Bikes and Tom Ritchie Components. My buddies in Vancouver, legacy is slightly different. They put bikes back together, but they didn't really build on the bikes. So their legacy are runs on the North Shore like Harvey's Wallbanger or Nick's Nutsack. So I guess they were drinking IPAs while the Marin County guys were forming and pushing out IPOs. So different legacies, but if you actually research farther past Wikipedia, you'll realize that people were modifying mountain bikes long before the 70s. This is a US infantry group that rode from Missoula, Montana to Yellowstone in 1896, more than 400 kilometers each way. Now you'll also look and go, those bikes are beasts. Those are about 80-pound bikes. So there's been a huge evolution in the equipment used. Some of the more seminal moments in the equipment, someone invented or modified suspension forks to work on the bikes in the early 90s. So when you ran into something, you were more likely to roll over it than flip over it. And this was very quickly followed by also rear suspension, which again was a huge advantage for safety. And equally important was when disc brakes were modified and added to bikes. And this was the late 90s. This allowed a lot more stopping power. So took people out of a lot of risk. A lot of the early pictures, you'll see people in jean jackets and jeans, no helmet and a hiking boots, and usually dragging a hiking boot because they were clearly exceeding the abilities of the bikes. And that was witnessed by the number of bikes I watched being welded back together. So much like bikes have evolved, safety equipment has greatly evolved. Clearly, mostly helmets are worn. Initially, we used road helmets, but then we also had mountain bike specific helmets with a lot more occipital coverage. Full face masks are worn, often braces on the neck and braces on the elbows. Braces on the wrists. And I'll predict that the next big safety change we're going to see is we're going to see airbags. Airbags are used in motocross and have been adapted and used in horse riding eventing which are very, very effective sort of vest airbags. And the only reason we haven't seen them in cycling is because they're too restrictive on the chest for the exertions of cycling, and they're too warm. But I know somebody smart is going to figure that out. So I know we're going to see similar adaptations in safety equipment. And while all of these adaptations to the bike are safety equipment, they've just allowed people also to do crazier and crazier things on the bike. So that's where the bikes came from. Where have we gone? Well, to the layperson, mountain biking, if you say mountain biking, they'll think of cross country. And that's partly because it's an Olympic event, and it's also partly because it's one of the more popular events. It is a 4 to 6 kilometer course with the number of laps done timed to be 80 to 100 minutes. Often always in the woods, often huge climbs you couldn't even imagine riding up, let alone racing up. And more we'll see big technical events added. The first race I encountered was in 2006, a practice at the Commonwealth Games in Australia. And the bikers really were frustrated with the course. The Canadian bikers were very frustrated with the course because they found it just a dirt road with a big climb and boardwalk. And the race developer was actually really proud of it because he had added a whole bunch of stumps that they had to roll across. And the Canadians particularly, but Canadians and Americans are really known for their technical skills. And the course designer came and talked to the Canadians and said, what do you think of the technical parts? And to a person, they hadn't even noticed. They hadn't noticed that at some point you had to jump about a foot. And that was 2006. This picture's from 2012. And this is a rock hop that was considered very big at that time. It's more of a rock drop, which they really didn't have a lot of technical things, but now they're a lot more technical. And sadly, the Euros have caught up. It was very fun in 2012 to watch the Euros ride up to the rock, stop, and sort of scout it out. And truly, they were just waiting for the Canadians. And the Canadians were so technically good that not only did they take great pride in not scouting anything out, but on the fly, they could scout out the right route, the completely wrong route, and the wrong route that they could pull off. And they would go off the wrong route that they could pull off. So unbeknownst to the Euro, they were showing them the wrong way to go off stuff. Now, unfortunately, the Euros have sort of caught up, and mountain bike courses have become a lot more and more technical. And if you've never seen a mountain bike race, it's truly amazing to watch because they'll ride up and over stuff you'd never imagine walking through. And they do it at a full-on exertion for the 80 to 100 minutes. The only time they're not riding flat out, they're clearly going over stuff very, very sketchy. So it's very cool to watch. Another discipline that's super cool to watch, and I'd strongly recommend you Google it if you haven't seen it, are downhill bikes. These guys race from the top of the mountain to the bottom of the mountain. So usually extremely steep, usually extremely sketchy with either loose gravel or scree or mud, often big air, and not unfrequently what they call rock gardens, which really aren't genteel gardens at all, but more boulder fields. Now, the cross-country athletes give the downhill athletes grief because they don't ride their bikes to the top. They often take a chairlift or a car. And similarly, the downhill athletes tease the cross-country athletes at how slow they go down. The downhill bike and the cross-country bike are wildly different beasts. This is a much beefier bike with a lot more travel. Well, because of the abuse of these two, of course, a whole new sport was spawned called enduro, which is truly a hybrid. So in an enduro race, which is getting more and more popular, only the downhills are timed. So there'll be 1 to 3 sections of downhill, which they time, and that counts for your results in the race. But they have to ride up the hill. So it has to be a bike that they can ride to the top of the hill. There's also short track. The cross-country events are always held in the woods, and the UCI decided they wanted to showcase the athletes more. So they would invent a race that would occur on a shorter race that would occur on the Friday of a long weekend, of a World Cup weekend. Initially, this race was something called an eliminator, which was a sort of 500 to 1,000 meters, usually something pretty technical, like a staircase or a really steep, muddy slope. And they would go off in heats of 5 to 6, doing heats until they had a winner. And it never really caught on, particularly amongst a lot of the more serious cross-country athletes. The technical riders tended to love it, but it didn't really catch on. So they sort of have switched away from eliminator to the current thing they're trying is called a short track, which in cycling terms is really a dirt criterion. So they do sort of 750 meter to 2K race on streets that usually involve a really steep climb and often the grass or a dirt part. to showcase how good these athletes really are. And in an effort to get the athletes to compete and to compete aggressively, your placing in the short track strongly affects your start position in the cross country the next day. So this seems to be an experiment that's really working. Now, looking at other things, there's, the cross country can be really extended to marathons, which tend to be 60 to 120 kilometers. There's ultra marathons that are 200 to 220 kilometers. There's multi-day stage races that are up and around 800 kilometers. And those are more on cross-country events. Obviously, very different skill sets required. And then there are a couple disciplines that you have to show videos to understand. Now, my dyslexia kicked in. This is not trails, this is trials. And trials can either be sort of free riding or free form, doing really foolish things in public places, or it can actually be organized events. Like, what could possibly go wrong there, right? These are phenomenally skilled athletes. The events are like this, where there'll be 4 to 8 obstacles, of which they'll have a bunch of targets that the athletes hit as many of them as they can in a time period without ever taking their feet off the pedals. So really a very different sport, but it falls within the realm of mountain biking and obviously very high risk, but also extremely talented athletes. And you just have to wonder how many injuries occur to get to this level. And then moving to another extreme, there's lots of examples of stuff like this. This is an ice mountain bike race where a certain number of participants go to the top of the mountain and race to the very bottom of the mountain in the spring. So they start on hard snow, move to slush, move to mud, move to dirt. And what could possibly go wrong? Now, I want to point out again that these are studded tires. So these are weapons that are bouncing all around. Wouldn't you love to be the person that signed on to cover that event? So what we've covered there is really just the tip of the iceberg of what people are doing on bikes, on mountain bikes. It's quite crazy. Moving on to medical things, these are very elite athletes. They ride really, really hard. So we get all of the common injuries. We get the tendinopathies. We get the saddle sores, and I'll joke, I'm going to spend 30 minutes now talking about saddle sores, but I'm just going to leave that for Wade next week. And we're going to emphasize more trauma. Now, if you haven't seen the trauma and someone comes into your office and says, I crashed my road bike, or I crashed a bike on the track, or I crashed the BMX bike in training, you'll probably have not an unreasonable idea of what they did, and you probably won't be super far off. But I can promise you, if you have a mountain biker, they might have done something that even in your wildest imagination, you're wrong. You haven't got it. And I always think knowing the mechanism is so important. An example of this, we had a Royal College Emerge resident, I think in her 4th year, so a very advanced resident from the East, and I don't want to bug Toronto, so I won't say where she was from. She wanted to move to BC, so she ended up doing a month with us in Kamloops. And they really come to see trauma, and we see a lot of trauma. And one shift I was working with her, she got super excited because we had a trauma code into the trauma 2, and she wanted to run the code, so in she goes. And she's all excited. This is going to be the big trauma. And she comes out about 15 minutes later, and you can see she's just oozing the disappointment because she's assessed that not only is this not the big trauma she was waiting for, but she feels that this hasn't even qualified as a traumette. And she tells me this is a 32-year-old who crashed on what he describes as a moderate-sized jump, and he has a little laceration to his leg. And she's just oozing disappointment. But I know the triage nurse that sent this person to the trauma, so I know there's more to the story. And I asked her if she asked him what a medium-sized jump was. And you can see the stifled eye roll, but in she goes and asks, and comes back out about 2 minutes later and still oozing disappointment, and says, well, he says a medium-sized jump is 75 feet. And I said, well, what do you think of that? And she said, well, I think he's lying. It's like, okay, did you ask him if he has video of what he did? Because more and more people have video of what they did, and he did. And he wasn't lying. He had a 75-foot gap jump. So he had made a kicker of a launch and then a landing pad, and they always try and land on the downhill. And the gap between these two structures was 75 feet. Now, unfortunately, he hadn't flown 75 feet. He had flown 90 feet. So he actually landed on the flat part down the hill from where he was supposed to land. And he landed it perfectly. He landed it on both of his wheels. Now, unfortunately, he landed on his practice bike, which had had a lot of impact. So when he hit the ground, his bike exploded. And you're looking at this video and looking at this guy who's obviously got road rash, but you're thinking, how is he alive? She really got it, that the story is everything. Stuff that's different, the trauma. So obviously on the road bike, on the track, you can hit things, but the probability of hitting things is much higher where the mountain bikers race, which is in the woods. There's a lot more obstacles to hit, like trees and rocks. There's also stumps and little saplings, which are like 1 inch in diameter trees that have been cut off so that they don't affect the trail. But the little tiny sharp stump is left there just waiting to pierce something. The other thing about mountain biking is, though often we hit high speeds, quite frequently the speed isn't as high, so the separation from the equipment isn't as much, and you get injuries from the equipment. This is one of the Euro guys who didn't quite successfully go off the rock I showed you earlier. And the interesting part about this picture, it was just fluke I got this picture. When he crashed, I was convinced he broke both of his wrists because they bent a direction wrist shouldn't bend. But fortunately, he wasn't knocked out, and he spoke English, and he could tell me that his biggest injury was the back of his head. And when you looked at the back of his head, there really wasn't much to see. He had a little tiny line at the back, but when you grabbed his hair and lifted up, his scalp lifted up like a garage door, because he suffered about a 40-centimeter laceration from the bike rotor. That's the little gray thing with the dots on it. That's the thing that so effectively brakes, but it turns kinetic energy into thermal energy. And so he'd totally cauterized this wound, and it would have been really easy to miss it. You know I got to bring up savage stuff, right? So the other thing about trauma on mountain biking is that it occurs in a remote setting. On the track, on the BMX track, you have to figure out what door or gate the ambulance goes to. On the road, you have to figure out what road coordinates to have the ambulance pick you up. But in mountain biking, more likely than not, the ambulance can't get to where the person is injured. So you have to bring the injured person to the ambulance, and you have to have plans accordingly. And then when I was preparing to do this talk, I also ended up covering a mountain bike event up at the local mountain. And the national physio, Tara Lazarski, who's an awesome physio, who covers the national mountain biking team and also a professional enduro team. And I told her I was doing a talk on the difference between mountain biking and injuries and the other injuries. And quite honestly, I wasn't sure what I was going to do, but I knew I was just going to make fun of bad injuries. And I figured I'd give Tara a week to come up with some ideas, but she didn't take a second to tell me that this is a super easy question. Because she said, mountain bikers fall a lot. And sometimes when they fall, they're fine. I'm good, thank you. And sometimes when they fall, they're not fine. And you have to be able to tell the difference between them. Now, I knew I was speaking after Richard, and I knew Richard was going to do high tech. And everybody that knows me I can't do high tech. So I need to thank my 10-year-old for that high tech part of the talk. So Tara's rules, they fall a lot. Just because the crash you just witnessed looked horrific, they might only be hurt and not injured. And just because the crash looked really easy, they might be injured and not just hurt. So you have to really be very careful the way you assess them. And then the other thing she raised, which I had never occurred to me, sadly, is that they walk on their hands, i.e. during really technical parts, they will weight bear fully on their upper extremity with no weight bearing on their lower extremity. So an injury to that area has a lot more ramifications for their participation in the sport. So thank you, Tara, for adding the educational part to my talk. So how many mountain bikers and what is the injury rate? Well, this is the Kamloops Bike Ranch. This is a city-owned and city-run park within the city limits of Kamloops. It's about 2K from my house. And within this park is complete madness. This photo should be credited. I stole this photo. So this is what's considered a medium-sized drop. So 10 to 15 feet is a medium-sized drop for real mountain bikers. For me, 6 inches is a medium-sized drop. But despite these terrifying obstacles in this park, we seemingly see very little in the emergency department in Kamloops. And I tried to quantify that. So when Wade asked me to do this talk in mid-August, I put a sign up in the miners department of our emergency department saying, please, if you see someone from the bike ranch, please just put their name and their birth date and I'll follow it up. And from mid-August until last week, I saw 3 fractures and 1 rule-out fracture. And unfortunately, or apparently, I saw all of the injuries. because nothing else was on the sheet. So despite the brilliance of my research design, I sort of questioned the robustness of that data. So I looked farther. Sun Peaks Resort is about 45 minutes north of Kamloops, and it's certainly known as more as a ski resort than a biking resort. But like most ski resorts, more and more they're adding biking in the summer. Now, though I'm the co-medical director of the mountain, I wasn't entitled to the absolute numbers, but they gave me the ratio numbers. Sun Peaks this summer, despite COVID and limited passes, had more than 20,000 people ride the lifts there. So they had more than 20,000 people riding, or sorry, yeah, 20,000, more than 20,000 riding there, because cross country or riding up the mountain won't count in the stats that day. In the last 5 years, 1.25 to 1.8% of the riders are seen by the bike patrol or seen at the clinic for an injury. So that won't be all of the injuries, but that's the injuries that have sought medical attention at the mountain. And that number seems really low to me. Like, what does that number mean? Less than 2% get hurt. Sounds pretty good. Is that accurate? Well, we saw 20,000 bikers this summer, that we get about 400,000 skiers, and this injury rate in skiers is 0.1, skiers or boarders, they're mixed together, is 0.15 to 0.2%, so almost a 10-fold less injuries. And though mountain bikers do crazy things, skiers and boarders also do crazy things. So I guess the incidence is kind of high. And how bad are these injuries? Well, 45 to 55% of the mountain bikers needed transport to higher care. Now, it's super important when you look at that number to understand that at Sun Peaks, there's very little in the way of care other than patrol. We have an emergency medical response team, so there might be an emerge doc and an emerge nurse there, but significantly, there's no imaging facilities up there. So the vast majority of those transports were for imaging. And skier numbers, very similar, 40 to 51%. So there certainly are injuries that occur from these sports. So let's play with some injuries. I know you guys are hanging in there really well tonight. This is a 13-year-old I saw in early May. Now, he did not crash his bike. He was riding his bike towards, fortunately, his mom's car, and he hit sand. So the bike stopped and he simply stepped off, lifted his bike up and rode off. Didn't think anything had happened, but within about 2-3 minutes, he felt intense pain. This is his right knee. This is his proximal tibia on the right side. So within a few minutes, he felt a lot of pain. And by the time he got to the car, they noticed blood. So they thought they should come in and be checked. They were seen by very astute triage nurses who recognized what he had. And then I went and saw, and so they triaged him to a high acuity area. I went and saw him, and by the time he was in the bed in the emergency department, it was still only about 30 minutes from when this injury occurred. And he still only had localized pain. And the reason the nurses had identified it is this is a rattlesnake bite. Now, about 15 minutes later, he developed nausea, vomiting, and horrifyingly to him, diarrhea, and also tachycardia and tachypnea. So he developed all sorts of signs and got antivenom and did great. I, on the other hand, got severely traumatized by this because when I moved to Kamloops, I was promised that the snakes were on the north side of the Thompson River. And I live, work, and never on the south side of the Thompson River, and I never go to the north side because the creatures on the planet I'm most terrified of is snakes. And it doesn't really matter if they have venom or not. It more matters if they have legs. And then the other fun case to play with, this, unfortunately, our emergency department made the national news a fair bit this summer. And this was not my case, but I was working that day and ended up chatting with him and got his approval to give this talk as part of the talk. He was pretty euphoric, I think, to be alive. So this was a 51-year-old gentleman who was riding with his family, but fortunately in front of his kids and wife, when he rode into a grizzly bear and her cubs. Now, he didn't actually ride into them, but he said suddenly there were 2 bear cubs there. And he said he had just enough time to think, gee, I hope Mama Bear is, meaning not close, when she tackled him off the bike. She then picked him up by his head and flipped him over and then attacked his groin and legs. Now, the very significant part is he had no head injury. The only mark on his head and neck was a minor abrasion from the strap of his helmet, and he had had his whole head in the grizzly's mouth, with the grizzly chomping down enough to fling a 180-pound man over. So I think he would have probably had an open fracture if he had not been wearing this helmet. So what a great ad for the Giro helmet company, eh? And he did unfortunately have some pretty severe leg injuries. Now, I want to be clear that this is an extremely unusual case. There's thousands of bikers spend thousands of hours riding at very high speeds in the mountains in BC, and these things simply don't happen. And indeed, at Sun Peaks, I think 2 or 3 years ago, for 2 years, we had a black bear and her 2 cubs who lived in the bike park. So they were always close to the trail, and I was just waiting for the call that someone's ridden into one of them, but it never happened. So rare, rare, rare. So we're on the home stretch here, people. If you're asked to cover an event, I hope I've made it really clear that you better understand what the event is. There's an enormous variation in the risk you're going to see, and there's an enormous variation in who is competing. The higher level people are very good at biking, and so they're a lot less likely to fall. But if they do fall, they're probably going to be much more injured than the lower, well, hopefully much more injured than the lower level people that hopefully keep within their skill level. And you need to plan your gear and position your emergency equipment accordingly. And there's some pretty cool emergency equipment. That's a backwoods stretcher, which we can talk about in questions if you want. Last slide before the conclusion. So you've done great. I love the drop sign in this. That's a very bad sign. So I think it's always a huge advantage to know the mechanism of the injury. So it's perfect if you see it. I think it's highly worth asking someone if they have a video, because before people do stupid things nowadays, it's remarkable how many of them film it. But just in case neither of those happened, I'm going to let you in on some of the lingo that the bikers use, because it can be quite useful in your injury assessment, because they have a whole different language. So if they use the term Superman, that doesn't mean something came along and saved the day. It means something occurred that probably ruined the day. To Superman is to leave your bike, not wait for your bike, but to fly over the handlebars. Now, mountain bikers think they have superhuman abilities and they think they can fly. And really, they can fly a lot farther than humans should fly. But at some point, they still land. And as my parents used to say to me quite frequently, there's consequences of that behavior. So that can be a bit of a problem. To scorpion equally is a very bad thing. To scorpion is to land on your trunk and have either your legs and or your bottom trying to hit your head. So you're bending your trunk the wrong way. So once again, not a good thing to have happen. Casing a tabletop, or to have cased a tabletop, has nothing to do with putting furniture in a box, but more to do with landing a jump short. I mentioned earlier that they always try and land on a downhill so they can roll out. And worst case or best case scenario in this bad situation is they land on the flat surface before the downhill, but all too frequently they'll land on the vertical surface going up. But either way, to case something is to drive yourself into the ground. Now, the really experienced guys will throw their bike away if they know they're going to come up short, throw their bike away so it's just their body that goes into the ground. The inexperienced people, or the people that don't realize they're going to case something, land with their bike and often try and drive through their bike in an effort to beat it to the ground. So once again, really bad consequences. And then lastly, the term, I really sent it, or I'm really going to send her, or I really send her, is the mountain biking equivalent of hold this and watch my beer. What follows that statement is usually epic, and only time will tell you whether it's epically good or epically bad. So, in conclusion, mountain biking can mean a whole lot of different things. And if you're covering an event, make sure you understand what you've gotten into. They sometimes are injured, sometimes they're not. Be ready for anything you might face though. And then of course, most importantly, is that mountain biking is the best event. So I really thank you for your attention and happy to answer any questions.
So if everyone can just put any questions into the Q&A, that would be fantastic. There is one question comment in there, Bruce, if you want to comment.
Yes, that's an excellent question. And it's a super controversial area in mountain biking. Is the question is, with the trend to e-biking, are we seeing more injuries because people can get out there farther? honestly, it's super controversial. A lot of the cross-country and enduro athletes really resent the e-bikers. But around here, Kamloops we have the bike ranch, and then we have 3 other very big biking areas. And e-bikes have intruded there, but so far it's been quite fair. And no, I haven't seen a change in injuries. Now, the other thing, the opposite of that question is we did have a acute coronary syndrome from one of the bike parks of a guy who had a heart attack trying to climb the hill. So e-bikes, I think, will have disadvantages, but I think they'll also have advantages. That's a really a great question. And that's a huge trend, because e-bikes are once again, just another discipline in mountain biking that's wildly different.
And Goudie's comment is that Bruce has an e-bike. Just wondering if you would confirm that or not.
I have a capital E, small b bike. My e-bike, I don't think I'd ever take off-road. Okay, so will you show the backward stretcher again? And is that a wheelbarrow wheel? No, it's not a wheelbarrow wheel. It's bigger. I will show that. It's a very cool stretcher. I'm embarrassed to say, oh, I'll try and show it again. So I'm embarrassed to say that I first encountered that in 2012, and I thought it was the best thing since sliced bread. We played with it, and that wheel is about 16 inches. And all of the weight of the individual will go on that wheel, and all you have to do is then steer them down. And so I was really impressed. That wheel will roll over logs up to 2 feet high and roll across creeks. So very, very slick. I took it to the head patrol at the mountain when I saw that picture to show him, saying, you know, this thing is the best thing since sliced bread. And he gave me the look that I get far too often, which is really like, how do you manage to put your clothes on in the morning? Didn't say anything, and he just motioned me into the back room. Motioned me into the back room where there were 3 of these that I wasn't even aware of. But the ones we have at Sun Peaks are different because they actually have a brake system, but a brake system more like a walker, so that you actually have to disengage the brake. So if the guy on the high side ever actually let go of the handles, the thing would stop rolling. Because he said these things are really, really dangerous because they can actually free roll for a little bit and then have a bad consequence. So most mountain resorts actually have these. They are brilliant for evacuating people. And remarkably light. The one we have at Sun Peaks with the braking system is about 60 pounds. So you still, when you do have to lift, it's significant, but you don't actually have to lift that often because they're a very slick apparatus. Great question. I think people want to go to bed.
It's quite possible. That is a fantastic talk, though, Bruce. Thank you very much. So if there's no further questions, I think we'll end tonight's session here. Thank you, everybody for attending. Both talks were fantastic. Just a little bit of housekeeping and note for next week. We are going to start a little bit earlier. We're going to start at 7:30 next week because we have 4 talks, so it's not a terribly long evening for the East Coasters. I know you West Coasters, that'll still be nice prime time for you. So it'll be 7:30 starting next week, and that will be our final session of the series for that. So thank you, everybody, and have a great night.
Bye, everybody.